Hi, good morning. My name is Jack Wixted, coming to you from Boston. I want to start by thanking the Harvard Global Orthopedic Consortium for allowing me to speak with you today. They've asked me to give you a brief presentation on late presenting femoral neck fractures in young patients. I also want to give a thank you to the Orthopedic Trauma Association for their support of the Harvard Global Orthopedic Consortium. And I would also just let all the participants know that the Orthopedic Trauma Association is really a super organization. They've got a lot to offer. And for educational offerings, for those of you in residency programs or in training programs, the OTA has a great trauma curriculum that's available online. You may want to take a look at that. So for today's objectives, we're going to talk about femoral neck fractures in young patients, how urgent they are, what our options for treating them might be, what kind of implants we might use, and what kind of complications we might expect after taking care of these kinds of injuries. By way of disclosures, I don't have any disclosures which are relevant to this talk. I am a member of the OTA Basic Science Committee, and I want to give a big shout out to Greg Gaske and the OTA Core Curriculum Project. Some of the slides have been taken from Dr. Gaske's talk. I have a talk there myself on tibial plateau fractures. So I, again, would urge you all to take a look at the core curriculum section of the OTA website. So we're going to start by talking about femoral neck fractures in young patients and how urgent they are to fix. Of course, we would like to get to these as quickly as we can. Now, what's a delayed presentation in my setting and what's a delayed presentation in your setting may be entirely different. So we're just going to talk about this patient. This is kind of the typical patient that I'm concerned with a late presentation. This is a young woman who fell down in her driveway and had a very late 3.5-month delay in diagnosis. Initially had an X-ray and probably had a non-displaced femoral neck fracture, was sent to physical therapy and was treated for several months with physical therapy before anybody identified that she had this femoral neck fracture. And this is a real challenge, even for you, certainly with late presentations and with us as well. This is probably something that many of you are seeing more frequently than we are, just based on your practice patterns and who's coming in and out of your hospital. It sort of begs the question as to whether or not, there's any late which is too late. And, I guess the answer to that largely boils down to whether or not you have access to arthroplasty options. So if you have good arthroplasty options in your hospital, then there may be a too late where you move to arthroplasty rather than fixing the patients. For many of you who don't have access to arthroplasty or whose patients can't afford arthroplasty, then certainly fixing these, even at a late date, may be your only option. And, you can get a pretty good result on these if you tackle them, appropriately. Of course, every patient that we take care of starts with history and physical examination. And I would point out that, your discussion with the patient really should focus on whether or not they're a high energy patient or whether they're a low energy patient. In the situation that I presented, I had a young woman who fell in her driveway, definitely low energy injury. Those are much more likely to be amenable to late fixation. High energy injuries, hit by a car, shortened extremity, those are going to be much more difficult for you. And you should know going into it, which one's going to be the challenge. So low energy injuries, much easier to take care of. High energy injuries, watch out. I won't belabor the anatomy here. This is something where most of us as surgeons are familiar with, and I have a limited amount of time today. So we're not going to talk too much about it. But as we know, the blood supply to the femoral head comes largely through the deep femoral artery, and then it goes, through the neck and up into the head. And disruptions of the neck, particular intercapsular fractures, can really cause a great deal of problems with late avascular necrosis. So if you have the greater degree of fracture, displacement that you have, the greater risk of vascular displacement that you're going to have. It is surprising sometimes, even with this, and even in badly displaced fractures, you can still get them to heal. Surprisingly, given how frail the blood supply can be. For imaging on these, I'm not going to get a lot into advanced imaging because many of you don't have access to that. Traction films can be helpful for this, for planning. I would say make sure you get a good AP and a lateral X-ray. If the patient can't tolerate a traction film, you can always get a traction film in the operating room. But, just make sure you know what you're taking care of before you go in there and have the wrong sets of implants. So AP pelvis is helpful because it gives you the opposite side. So you can check the neck shaft angle on the contralateral hip. And traction films can really be very helpful in straightening things out and making, a complicated fracture pattern a little more clear in your mind. Again, advanced imaging, CT scans, super helpful if you have this access. But again, you don't really need this if you don't have it. Just so we're all on the same page, I'm going to refer to these as either subcapital or basicervical. And, my sort of take on this is that the subcapital fractures are clearly intra-articular and the basicervicals are largely extracapsular. Sorry, subcapitals are clearly intracapsular, and then basicervicals are largely extracapsular, and these transcervicals are sort of right at the level of where the capsule inserts. So subcapital, transcervical, basicervical. I'm not going to go over the Garden classification. Most of us are familiar with this. I will say that conceptually, I think the Powell's classification is helpful. It keeps your mind oriented towards what's in valgus and what's in varus, what's in compression and what's in high shear. So Powell's type 1s, less than 30 degrees, those are much more likely to be in compression. You're much less likely to have problems with shear, and your union rates are going to be better. By the time you get up to Powell's type 3 classifications, you're looking at a very steep angle here, right? Very high amounts of shear and far higher rates of non-union. Just getting back to our original topic, which was, time to surgery, this is sort of becoming less controversial. And if you look at many of these papers, they're comparing time to surgery of before 24 hours or after 24 hours. The more recent papers here have been looking at, cutoffs of 24 hours. If you look at the Heidekevich paper, for example, back in 2004, 24-hour cutoffs, no real difference between, before 24 hours or after 24 hours. What really mattered most was initial displacement. The Duckworth paper here, 122 patients, 32% complication rates. Greater than 24 hours did show an increased failure rate. And I know for many of you, you're thinking, Jack, are you crazy? We're seeing these patients 3-4 weeks out, not 24 hours or 48 hours. So again, this is largely, whether patients are early or late presenting largely depends on the system that you're in. So if you can get to them early, awesome, get to them early. If you have young patients who show up in your hospital and they're 12, 24 hours out, prioritize those patients, get them done as quickly as possible. But I know that many of you will be seeing patients 3, 4, 5 weeks out, and those are the real challenges. So by definitive management, you really have a couple of choices here. Am I going to open this, right? Is this going to be an open reduction, or am I going to do a closed reduction, accept my reduction, and then put my hardware in based on the best closed reduction that I can get? So I would say, for definitive management, your ORIF is largely going to be sliding hip screws, cancella screws, and blade plates. We do have some modern plating systems, some locking plating systems that you might consider using. We have some fancy hardware that's available to us. Again, I think you can do most of these cases perfectly well with a good reduction, a good approach, and standard hardware that you probably have available to you. By approaches, the workhorse for this really for me has always been the Smith-Peterson approach. Anterolateral approach or the Watson-Jones can be quite helpful as well. And I did a Watson-Jones approach with one of my partners recently. We had good visualization. The nice thing about some of these is that it facilitates or makes things easier to get your hardware in. We'll go over that briefly. So by way of open versus closed reduction, you know, when I was in training 20 years ago, the mantra was always you needed an anatomic reduction, and that meant you had to open it. And it was kind of a point of pride for trauma surgeons to be able to say, oh, yes, I open up all of my femoral neck fractures and they all come out great. Of course, that's not the case. Many of these that we open don't do that well. And some of the ones that we treat without opening, we get a good closed reduction on a fracture table, for example, actually do just fine. I think what really matters is the quality of your reduction, not so much whether you opened it or didn't open it. If it's in varus, it's not going to do well. If you have a lot of posterior tilt, it's not going to do well. If you can get it generally well aligned without opening it, awesome. If you have to open it to get it generally well aligned, also awesome. But leaving it in varus or leaving it posteriorly angulated is a recipe for problems. Getting it as close as you can to perfect, whether that means a good closed reduction or a good open reduction, is fine, but you do need to get that good reduction. The difficulty comes in when you try a closed reduction and you put the patient on the fracture table and it's not that good. You really have to have the impetus to say at that point, okay, things aren't going the way I thought they were with the fracture table. Now it's time to open it up. So having that skill to open that up is important, even if you aren't planning on it as your first approach. Uh, in JOT in 2020, this is a very recent paper, and it's changed the thinking for a lot of people who were sort of very, strict about making sure that all of these got opened up. This was an interesting paper, 234 patients with displaced femoral neck fractures, generally young patients, right? 18 to 65. The reoperation rates with open reduction was quite significant relative to that with closed reduction. So there's some evidence here that closed reduction is perfectly acceptable as long as you get a good reduction. So the risks of reoperation with open reduction were significantly higher. Now, there was a lot of effort in this paper put towards trying to control for variables like difficulty of the reduction, complicated nature of the fracture, to make sure that these groups were comparable. Suffice it to say that even with an open reduction, you certainly are going to have a high reoperation rate. And this has made a lot of people rethink their strategy. Largely, my strategy has been put the patient on the fracture table, see how much of a reduction you can get. If you get a good reduction, great, put in the hardware. If you get a crappy reduction, take them off the fracture table and open up the hip. When I say open up the hip, what do I mean? Well, there's a few ways you can go about this. I think technically the easiest approach, if you haven't done a lot of these, is to do an anterolateral approach. Put the patient in the lateral position. You'll be staring at the vastus lateralis. The abductors are easy to identify, and releasing the anterior third of the abductors brings you right down on top of the neck. I find this to be a very simple technical surgery, and you can put the hardware in from the same approach. The downside to the anterolateral approach is that patients will limp, and you need to do a good repair of that abductor. And some of those patients, even with a good abductor repair, will still have some problems with limping. So although I do find that the anterolateral approach is technically the easiest approach, it's also the one that's most likely to leave the patient with a limp. So if you've got a very late fracture and you've never done a Smith-Peete or you've never done a Watson-Jones, that's probably not a great one to start on. If you're going to start on the Smith-Peete or the Watson-Jones, start with a fresh fracture. Don't start with something that's 3, 4, 5 weeks out. If you do have something that's 3, 4, 5 weeks out, the anterolateral approach is a great way to go if you don't have a lot of experience. The Smith-Peete is kind of the workhorse for me, has been, because I used to do a lot of pediatric surgery, and you can get really nice visualization with the few displaced femoral neck fractures I had in kids under the age of 12. The Smith-Peete gets you really nice visualization. My advice to you on this would be practice on the Smith-Peterson approach with patients who have a fresh fracture. trying to take care of a delayed presentation through the Smith Peak can be a real challenge. So practice your Smith Peak approaches for sure, but do it on patients with a new, fresh fracture so you can see what you're doing. The other problem with the Smith Peak really is that you need to put your hardware in from the side. You have to really do a separate secondary approach in order to get your hardware in, and it can be challenging if you don't have really good X-ray. So be a little bit careful about doing the anterior approach, a Smith Peak approach, if you don't have good X-rays. You'll see your fracture, you'll get a nice reduction, but you'll have a heck of a time getting the hardware in to hold it still. This is a nice look at reducing a fracture through the Smith Peak. Superior is at the top of the screen, and you can see the femoral head there. It's got a pin in it, and they're using these guide wires to joystick around the femoral head and get it back into place. Got this retractor here. This inferior retractor at the bottom is around the inferior portion of the neck. Just by way of comparison, I think the anterolateral Watson-Jones is a good approach if you've got some experience with it, and you can certainly do that in delayed presentation. It gives you nice visualization and it gives you good access to put the hardware in. The Smith Peak approach is a little bit more challenging if you've got a delayed presentation. You do get nice visualization, but you've got to get your separate lateral incision for your hip implants, and that's going to require good visualization. If your X-ray isn't awesome or you don't have a C-arm that's working real good for you, again, anterolateral Watson-Jones is probably your best bet. If you are unfamiliar with these, the OTA's got a great resource. They've had really nice video library. These videos are all vetted and they're really nice quality. I would strongly recommend that if you have the time, take a look at this ORF of the femoral neck versus an anterior approach. There's a great video on that. If you've got one of these coming in and you're a little nervous about it, take a look on the video. OTA is a great resource for that. By way of reduction technique, you can certainly drill a little bit of a hole in that top right-hand picture up here. I don't know if my arrow is showing, but up in this area, if you drill a little bit of a hole in the head, you can get one of the tines of your point-to-point reduction clamp, your large Weber clamp, into the bone and then reduce it against the troch. That gives you a nice reduction here. You can use K-wires and joystick it back into place. There's lots of ways for you to get these reductions done. Once you get it done, if you're through the Smith Peak, you probably have enough room to put a medial buttress plate along the femoral neck, and we'll talk about that in a minute. If you do have a Smith Peak, it's tempting to just want to put K-wires in from the lateral incision, and I think that's probably sufficient in younger patients. In the pediatric population, for sure, I think that's probably sufficient. But for most adults, if you've got a delayed presentation of femoral neck, you're going to want to use some kind of fixed angle device, a sliding hip screw, if you have access to one. That's going to be hard to put in through a separate approach. The collinear clamp is a fancy clamp that we have. Is quite expensive. I find this thing quite cumbersome and a little bit of a difficulty to put in. So I don't use a whole lot of the collinear clamps. Again, here's a nice picture of joysticking that femoral head back into place. They've got the wires here ready to go. They line them up right to the edge of the fracture, joystick the fracture in, and then advance the wire right across. So just a word of advice on the Smith Peak: get your wire into the troch, get it exactly where you want it, then reduce the head, and then quick spin the wire across the last, 3 or 4 centimeters. Okay, so by way of the medial buttress plate, here's another quick picture. This is a well-described technique for putting a little small frag plate, if you have access to this, to help your reduction. And you can do this either in conjunction with a blade plate, or you can do it in junction, in this case here, with a DHS. So there's a nice paper on this, JOT 2019. This lays out the anatomy of the femoral neck quite clearly. So if you're looking for a little bit additional reading, that's a nice paper for you. All right. This construct right here is for me the kind of workhorse of what I do with femoral neck fractures in young patients. So if I see them acutely, I'm going to put them on the fracture table. I'm going to get a good reduction, or I'm going to have to open them and get a good reduction. But either way, I find this is a pretty simple, straightforward, solid construct that works for many patients. Okay? If you have access to a sliding hip screw, it can be very helpful. A buttress plate is also a nice way to go on this. It can be technically challenging to get these in. The Smith Peak gives you pretty good visualization of it, but in order to really do this fracture justice, putting in this medial plate can be hard, and then putting in the DHS through a separate lateral approach can be hard. This requires really good x-rays. So if you don't have good x-rays, don't try and get fancy with this kind of a technique. If you have a great C-arm, this is a good way to go, but it can be really challenging. Cancella screws alone are tempting because you've done your Smith Peak, you've struggled to get your reduction, and now you just think, let me get some screws in here and go to lunch. Be careful. Cancella screws, I think, are fine for fresh fractures. I think they're fine for older patients. Younger patients, cancella screws are really not going to be enough for you. And I think in the delayed presentation, cancella screws alone also not going to be enough for you. If you are using screws, make sure you're using good technique. Here, we're looking at pretty good technique. We have nice spread on the AP where our screws are not all on top of each other. And again, here on the lateral, we're filling up that neck. The point of your 3 screws here really is to fill up as much of that neck as possible. So you really don't want the screws on top of each other. What you want is really nice spread. And here on the lateral, this is exactly what I'm looking for. I've filled up the entire neck on the lateral. Here on the AP, arguably, you could put this superior screws a little bit more superior. You could cheat them another 4 or 5 millimeters. You could put this inferior one a little bit more, another 3 or 4 millimeters inferior. Pretty good on the AP. I really like this lateral. Okay. Partially versus fully threaded screws. This is a little bit of a, there's some debate as to this. For myself, in my practice, I tend to find that many of these femoral neck fractures will fail in compression on the medial side and on tension on the lateral side. So the superior portion of the neck tends to be in pretty good shape. And I tend to use partially threaded screws over the superior portion of the neck and a fully threaded screw inferiorly. For these things that are delayed, like more than a week, really, even several weeks that I'm sure you're seeing them, my final tips on this, just by a little bit of a summary here, make sure you're getting a good reduction. Hey, put them on the fracture table, pull on them a little bit and see how close you can get them. And if you're not that close, open them up and get them pretty close. The second point I would make on these is you have to really make these stable. These delayed fractures really need a lot of stability, and screws alone will not be enough for them. I prefer to use a blade plate on these. I have good visualization. I have access to the implants, so it's easy for me to tell you to use a blade plate when you may not have access to one, but it's a great tool to have in your toolbox. And if you've got good visualization and you can get your hands on a blade plate, this is a really good indication for one. Medial buttress plating, technically difficult. This is one I might stay away from if you don't have good visualization. And then, put them on a fracture table, see how good you can get them. You might be surprised how good. This is typically, unfortunately, this is what you see when you use screws alone. Somebody tried to put these in. Screw position probably on the lateral could be, a little bit better. On the AP, could use a little bit better spread. But generally, these screws are just not strong enough to hold up a young patient. I think a little old lady who's doing a lot of sitting around is fine. Young patients, you're going to need more than just cannulated screws. We like to blame this. They had a varus malreduction and the head was posteriorly tilted. That may just be an effect of, them walking on this. So I'm not sure that's really the case that this was done poorly. Just be aware, 30% of these are going to fail. And if you look at series after series after series, failure rates, even with good reductions, 25 to 30%. So just be aware you're fighting a tough battle here. So if you see some failures, be objective about your hardware, take a look at your reductions, make sure you're doing the best job you can do, but don't be surprised. In terms of non-union rate with fixed angle versus cannulated screws, most people are reporting better results with fixed angle devices than they are with cannulated screws alone. So my suggestion would be if you have young patients, delayed presentations, don't be using cannulated screws alone. In the specific instance of femoral neck shaft fractures, we know that 5% of the shaft fractures in the femur are have an associated femoral neck fracture. So look for it, you'll find it. Those patients, I think, putting screws alone are sufficient, and plenty of screws. I'll put them in at odd angles. I'm perfectly happy to put in 4 screws. If you've got a femoral neck fracture associated with a shaft, stop your nail short and put some cannulated screws into the head. I find the blade plate to be particularly helpful. There's some nice papers on this. It's an older device, so you have to kind of look back on the papers. Here's a paper from 1998 describing the use of the blade plate. The one comment I would make about blade plates, for those of you who don't have a lot of experience with blade plates, be careful on the lateral. If you have small patients, 5'2", 5'4", women in particular, this blade plate is 13 or 14 millimeters wide. It can be really hard to get that thing into a small neck and not have it cut out. So be careful in women and in smaller patients. These blade plates can be really unforgiving, and it can be really challenging to get a standard size blade plate. They really only come one size. To try and get a standard size blade plate in somebody with a small femoral neck. Just be careful on that lateral, what direction you're going. You don't want to cut out the back. Getting back to my patient here, my 29-year-old, this again came in 3.5 months after injury. And I know many of my colleagues who are good at arthroplasty would say, give this young woman a total hip replacement. But that's tough at 29. I think at 49 or 59, 100%, give the patient a hip replacement. They'll do very well with that. But at 29, that's still pretty tough to give her a hip replacement. So talked it over with her, and we decided we would do the best we could without opening it up because we didn't want to increase her infection rate for subsequent hip arthroplasty. So we put her on the fracture table, and you can see we got a pretty reasonable reduction. We have a big gap down here, right? That's a really concerning gap. But nonetheless, the neck shaft angle is pretty good. Our Shenton's line looks pretty good. Tip of the troch, center of the head. We have a pretty good reduction here, and that's just on the fracture table alone. Now, what I like to do is put two cannulated screws over the superior portion of the neck. And you can see how closely I'm hugging the superior portion of the neck right there. I get my 2 screws in here over the superior portion of the neck, and then I'm compressing over the superior portion of the neck, and I'm pulling that thing down as much as I can to really get some compression over the top of the neck. And then inferiorly, to bridge that gap, I'm going to use a blade plate. So in this case, I had a nice 1-hole blade plate. You can see here, I bent the blade plate with the bending irons here, a tabletop bender, just to get that to fit a little bit better for me. 1-hole 1-hole blade plate. And that, held things very nicely for her. There she is at 2 weeks post-op, and here she is 6 months post-op, healed up very nicely. And I think this is a reasonable construct. I prefer to use a blade plate to a sliding hip screw. I think a sliding hip screw is fantastic. If that's what you have handy. It's technically easier to put in a sliding hip screw. It's not as stable as a blade plate. If you really want young patients to heal, get a good reduction, get a good stable implant. For me, that's a blade plate. It's the most stable implant I have to deal with femoral neck fractures. It's the one I choose for delayed presentation. If you don't have it and you do have a DHS, great. Use a sliding hip screw. It's technically far easier to put in, but it's not as rigid. In terms of arthroplasty, I think anybody over 40 who presents late, give them an arthroplasty if that's an option for you. Don't be tackling delayed femoral neck fractures or doing valgus intertroch osteotomies in patients for non-unions. If patients over 40, arthroplasty is a great option for them if you have that available to you. Of course, if you don't have that available to you, then you've got to fix them. And hopefully, we've talked about some options that you can consider today. If you are looking at femoral neck fractures in younger patients that go on to non-union, again, we know 25 or 30% of these are going to fail. Valgus intertrochanteric osteotomy is still a great way to go. There's a very nice video on how to do that through the OTA. Again, check out the OTA for valgus intertroch osteotomy. Okay, appreciate your time and attention. Summary here this morning, the choice of your approach really based on your fracture pattern. Ideally, you'd love to fix these within 24 hours, but if you can't, you can't. I think what really matters is probably not whether you open it or close it. I think what matters is how good you get it reduced. In my patient that I showed you, we had a pretty good reduction, and we were able to really augment that by putting 2 screws across the top of the neck and compressing superiorly, and then using a blade plate to give a really solid implant. I think in young patients, you need a good reduction. If you can get it closed, great. If you can get it open, fine. And I think you need really rigid fixation. So for my, in my hands, that really means blade plates. And then, of course, counseling patients is important. We all know ahead of time that 25 to 30% failure rate is a tough number. Patients need to be aware of that ahead of time so they can plan and be prepared in case things don't work out the way they think they're going to. Here's some references. I appreciate your time this morning, and I'm looking forward to the rest of the conference. Take care now.